So we start this first conference with workshop about hand and wrist injuries. As you heard with the previous speaker, there is not a lot of epidemiology of hand and wrist injuries in the handball. If you look at PubMed and you are looking for hand injuries in handball, you find only 5 articles and only 3 for the wrist. So there is a relatively poor literature about these injuries. We know that hand and wrist injuries in acute injuries is about 20% of all the lesion. And the type of lesion is tendon injuries, ligament injuries, fractures, and sometimes there is a combination of soft tissue injuries and joint injuries. So we will start with the hand injuries. I will start with the first case. You receive a patient who has a loss of extension of the DIP joint after a direct trauma with a ball. He's presenting to you with this finger. What do you think? Okay, yes. The first classical one, it's a mallet finger. It's the disruption of the terminal extensor at the insertion of distal phalanx. It's the most common closed tendon injuries in the athletic population, more than Achilles or every other tendon. We see this really commonly on sports with ball like handball, basketball, volleyball. The mechanism of the injury is usually caused by a ball striking on extended fingertip. It's an eccentric mechanism. And there is a forced flexion moment of the DIP joint when the finger tries to do an extension. The diagnosis is on pain, swelling, tenderness on the DIP, and deformity. The patient is unable to extend the DIP joint. X-ray should be always performed because it's impossible for you to do the difference between, when you see the patient, between a soft tissue mallet injuries and a bony mallet injuries. The soft tissue injuries is only about the tendon. The mallet is the bone insertion is broken. The treatment for soft tissue or non-displaced bony mallet finger is an extension splint of the DIP for 6 weeks to 8 weeks. Personally, for the sportive, I prefer to follow with the same period with a nighttime splinting. If there is any bony injury with a displacement fracture or more than 30% of the articulate surface, there needed a surgical treatment. This treatment will be with pin or screw or blade. So, second case clinic, the patient comes with impossibility to move the DIP joint after a contact injury. He presented this finger. What are you thinking about? No idea? It's not a fracture, it's not a mallet finger, it's a DIP joint dislocation. So it's a relatively common lesion on this joint, especially in contact sports like handball. The DIP joint has the same configuration on ligament as the PIP. So you have a strong volar plate, and you have usually a dorsal or lateral dislocation of the DIP. The treatment is always local anesthesia, reduction, and you test to see, you test directly the finger to see if there is any problem with the tendon. The treatment is the same as the mallet finger, except that the finger is put in straight position, no hyperextension. So you see for these two both injuries, we use quite the same, we use the same splint, but the philosophy is quite different. And the question to my colleague is how to prepare this DAP splint. Over here.
Good afternoon. So, when we will do the splint on the patient, we first take a piece of paper. We draw the finger of the patient on the paper, and then we make the line here. We divide the finger into, we draw the line in the middle of the finger. Then here, first we have to mark first the PIP joint and the DIP joint. When we draw the finger, we take our marks, which is the DIP and then the PIP. So second, we draw the middle line, and we report this space, the A, we report it here. We report, so half of the finger bilaterally, yeah? So here and here, and then we draw the model of our splint all the way around, passing by A prime, B prime. Then we cut the paper. We take this paper, we put it on an orphid sheet. We cut the piece of orphid. So,
Can you displace the camera?
so this is already the splint done on the finger of Bernard. I will just melt it again and show you how we do the splint. So normally it was done previously, but we can, even if it's done, we can remodel it again on the patient. So I put a piece of thermoplastic on the hot water. The water should be hot. We'll wait a few seconds, I hope. So we really have to wait that the thermoplastic becomes soft. This takes a while.
So with this kind of splint, we can permit the patient to continue training and continue competition. So there is no limitation. It's only a conservative treatment, and the patient is able to continue to play handball or to play volleyball with this kind of splint without any problem. It's good?
Yeah, I think so. It should be soft enough. Yeah.
The finger, we cut with the scissors, and we had this shape cut. We put it in the hot water, and we model now.
Okay, give me your finger. Well, this one is the size of Bernard, so I will put it higher. It has to go higher than the PIP joint, okay? And we wait a while. We put the finger in extension, okay? And we wait till the thermoplastic become cold. Okay.
For the mallet finger, let's say the focus is to keep the DAP, the last phalange in extension during the splinting. So we're
or hyperextension, 10 degrees of hyperextension.
Yeah, but also while we model it, to continuously keep it to control it very well.
It's really important to have an extension of 10 degrees, because if you have a soft tissue mallet finger, if you don't put any extension on the DAP joint, the two parts of the tendon don't touch and cannot heal. And the patient must wear this splint for 8 weeks, night and day. He cannot retrieve and flex the 8 weeks. He cannot flex the DAP during this period because it can be a failure of the treatment.
So as you see here, the splint is a little bit big for Nicoletta. So I can adjust it and cut all this part. And I recheck. Normally it's fine. The main thing is here is to keep the PIP joint free. So when we put the splint on with the Velcro, when we attach it here, the PIP joint has to be free. Okay?
Okay. So change it, continue. Flex, actively flex the DAP joint and with an hematoma. You see this kind of patient, what are you thinking about? No, no tendinitis?
It's a fracture in the distal pala.
There is no fracture? No. It's called a jersey finger. It's a flexor digitorum profundus rupture. So it's like the mallet finger, but on the palmar side. It's the avulsion of the flexor digitis profundus at insertion of the distal phalanx. Can you prepare the second one? Okay, thank you. So it's like, for the mallet finger, it's an eccentric lesion. There is a forceful passive extension of the DAP when the flexor digitis profundus is contracture. So it's not so common, but is often missed initially. And it's a disaster. I will explain you why. So when you see a patient with swelling, ecchymosis, pain, unable to active flex the DAP joint, okay, do first an X-rays to be sure that there is no fracture. Then, if the X-rays show no fracture, do an ultrasound or an MRI, because you can show here the small piece of the fracture on this young guy. This is the avulsion of the insertion of the FDP on the distal phalanx. Here you see the tendon is retracted on the middle phalanx. You see better on the MRI the attachment of the distal part of the flexor digitorum profundus and the proximal part retracted on the middle phalanx. And there is a good classification. The stage 1 is a complete retraction of the FDP. The stage 2, it's a retraction until the cross with the superficialis, the sublimis. And the stage C is an avulsion of the bone, and the flexor is still blocked here in the A5 poli. This is the stage A is the more emergency lesion. So the treatment is always surgical, and the timing is based on the degree of the retraction. More the tendon is retracted, more the reduction and the repair are urgent. And look at this. Sometimes we must open all the finger to take out the flexor digital profundus through the puli and to reattach it on the distal phalanx. After this, a splint with flexion of the wrist at 30 degrees and the MP at 60 degrees is necessary. We start a passive motion at the beginning. The strengthening can be not started before 2 months. And sometimes after 2 to 3 months, we must put a dynamic extension splint to restore the complete extension. Oh, prefer to have a picture. So this case is a patient who fell down, and he fell down on the floor, and the finger was flexed at his maximum, and he come to you with this deformity. He's not able to extend the PIP joint. What are you thinking? Yes. And the name? Boutonniere deformity. You're right. So the boutonniere deformity is the avulsion of the central strip of the extended hood on the basis of the middle finger. So the mechanism of injury is a hyperflexion of the PIP joint. It occurs when there is some drawing of jersey, or when the player fell down. You must do an X-rays and MRI to see the deformity. After this, you propose for this closed lesion to put an extension of the PIP joint with an invert A-B sleigh or a Kepler for the day, and for the night with a longer digital immobilization. So another PIP deformity after a contact injuries, and the patient presented to you with this. So it's on the PIP joint. It's not a lesion of tendon. It's a dislocation of the PIP joint. It's relatively common. I saw since the beginning of this competition, I saw 2 guys with dislocation and 1 with a boutonniere deformity. So it's not so rare. So the PIP joint is one of the anatomical and functional locus of the finger function. The mobility is about 100 to 110 degrees. The dislocation is commonly caused by hyperextension, and you know that in volleyball or handball it's relatively common. And the hyperextension can give an avulsion fracture of the insertion of the palm-volar plate on the middle phalanx. And Schenk gives this good description. The stage 1, you have only a bone avulsion. Stage 2 and 3, you have an avulsion with a dislocation, and the last stage with a fracture dislocation. And you see the patient before, he has a dorsal dislocation without any fracture. So the volar plate is complete rupture. So local anesthesia, reduction, and see if there is any loss of function about the extensor and the tendon. For the type 1 and 2, is splinting and syndactyly. Put a digital tubes in lycra to avoid any edema. For the type 3, it's surgical procedure because this is considered like a fracture of the middle, the bases of the middle phalanx. So, how to prepare the syndactyly, the digital tubes, and this splint?
For this splint, it's the same as the one before, but longer. So the DAP and the PAP are inside the splint. And so the splint goes till the MC joint on the dorsal part and until the nail, fingernail, little longer just to protect the fingernail. We leave the patient in a comfortable extension, so it will not be forced in extension like it was before for the mallet finger. So it has it is a protective splint. And so we take the shape same as before. We put the finger on a piece of paper, we draw the finger shape, and we sign DAP, the PAP, and we double the size of the middle. Okay, we cut the finger in half, and the half part of the finger we double right on the right and on the left to have the extra part to cover the lateral part of the finger. Okay, so we have this shape at the end, which is a finger shape. The finger is here, we have a little extra, and we'll put it on the dorsal part of the finger. Okay, so this is her finger. This is the shape. We put it on the dorsal part and make sure we keep free the MP. We keep the DAP and the PAP in extension, but a comfortable extension. Normally we don't force the extension. We shape lateral, this is almost perfect shape, even if it's Bernard finger, he has same fingers. And we close it with some Velcro. So we have to cut the Velcro, hit a little bit, we'll show you after, in the bigger splints. We'll hit a little bit the thermoplastic part, we attach the Velcro, and after the other part we close it. On the top, we leave the PAP free, and we close in the back as well. Yeah.
So avoid to have any prior extension on the PAP. It's a dorsal dislocation, or there is a fracture on the palmar side. So if you can put some flexion, a little flexion on the PAP, it will be better. Can you show us the syndactyly and the digital tubes, how to place it and to be careful? It's quite difficult to, for syndactyly, it's easy between the middle phalanx, or the middle finger and the fourth finger. It's more difficult for the fifth finger because the length of the fifth is smaller. So for me, for the fracture of the dislocation, put this splint that Nicoletta showed you for the night. For sleeping, it's more comfortable. For the day, it's better to allow the patient to start directly to move to reeducation with a protection of the syndactyly. This syndactyly will not permit to have a hyperextension of the consort finger.
So now I'll show you how to perform a syndactyly with the thermoplastic, okay? So we cut a piece of thermoplastic. We previously measured it. Normally we take a tape measure and we go around as an 8 between two fingers, and we take more or less the measure. Then we cut the thermoplastic, we heat it, you see, it's sticky. It's very sticky, exactly, so the water is very hot. So I take the piece, I come to my patient, I pass the thermoplastic between the two fingers, like this. I stick the part up, and I stick the part down like an 8. Okay? Then I'll cut this, and I'll cut this. We wait a little bit. It has to take the shape of both fingers. Okay? We just have to make sure that the size of the syndactyly is not too tight, because in the phalange is always thinner than the joint. So I always make sure to remove the splint a little bit on the joints, and then I'll take this and I have to warm it again with the heat gun. So I warm it and I close it very well to make sure that it doesn't take off. side. Second side. After we have to wait a while because the gun is very high, so it takes time after to cool down. And anyway, I will try my splint on the patient. Okay, like this. I can wait here. So the syndactyly goes always with two pieces, one between on the first phalange and one on the second phalanges. So I have another piece ready. Same procedure. So up between the two fingers, one goes up, one goes down, up, we stick and we wait. We have to go very fast, otherwise the thermoplastic becomes cold and it doesn't stick anymore. And this syndactyly will keep both fingers together. So if this finger doesn't bend, the third finger will pull it together and it will help the second finger to bend. Yeah, and we use this also to avoid any rotation of the fingers. Yeah, in the middle. Okay.
Really nice. Thank you. So we check. We continue. So, and he comes to you because his pain. He presents swelling and hematoma on the MCP joint. Your diagnosis, what can he present it? Yes. The more classical is on stress virus and it's acute UCL injuries. The patient are coming with swelling, hematoma in emergency. They can have big pain and it's difficult to examine, to do a good examination of this patient. But you must know that sometimes this lesion is an indication to operate. If there is any fracture, so it's important to have X-rays, good X-rays in good position, and to test this patient. And you must see this picture in 70, it was described by Moberg, and Moberg showed that the force to tear this UCL ligament is about 36 kilo. It's an old, well-described lesion. In 1955, it was first described by Campbell, initially for the gamekeepers. So the gamekeepers are the guy in England, they are killing the rabbit with the thumb. And after this, with the sports, it's becoming a more classical injury in ski and in football and handball keepers. So in 55%, there is no bone lesion. In 30%, there is an avulsion of the distal attachment of the UCL. And the most important is to don't miss a sternal lesion. It's necessary to do an ultrasound when you have this patient if there is any fracture. If you do the ultrasound and then the radiologist tell you, okay, there is a sternal lesion. The sternal lesion is the interposition of the adductor aponeurosis between the torn ligament and its normal insertion. So you see here, this is the adductor aponeurosis, this is the ligament. The normal insertion is exactly here. It's impossible to put this to to this insertion without any surgery. And there is a lot of handball players that have missed this lesion, and they have in the future some instability on the MCP joint. So it's a real emergency surgery. So we will speak about this splint, slight modified splint. You must use it if there is no displaced fracture or no Steiner effect. And this splint must be stay for 4 to 6 weeks. If there is any Steiner effect, it's necessary to repair the UCL ligament using an anchor. You put the anchor on the bone and you reattach the ligament. If there is any fracture, be really careful that the X-ray is well done. You see the same patient. This is a classical AP view of the hand. You don't see anything. This is the AP view of the same thumb. And you see the fracture here is displaced. So it's really important to have radiography, good radiography, and even there is no fracture, an ultrasound to be sure there is no Steiner effect. And for this fracture is the same. You put an anchor and you reattach the small bone piece, or you can put a small screw. So after the surgery, you must let this joint in relief for 4 to 6 weeks with this kind of splint. And this splint allows to move the wrist and the IP joint of the thumb. Only the MP joint is blocked.
So it's the same concept always. When the patient comes, we take a piece of paper, we put the hand of the patient, and we draw the hand, all the hand. Now here we draw all the fingers with the wrist. Then, before removing the hand of the patient, we make sure we take all our marks, which is the PAP of the thumb, the MC joint from both sides, medially and laterally. We take the MCP joint, we take of the thumb, we take the trapezometacarpal joint as well, and we take the wrist. Then we do the same. We divide always the hand in two. So we take the third, we draw a line passing by the third finger in the middle of the third, going till the middle of the wrist. Okay? After that, you see it's number 1. Number 2, we draw the line. We have the paper, we have our mark here, we draw the line from the MP line. Okay? Then we draw the wrist line. After this, we have, you see, I have the distance of the phalange, this distance, which is where is written IP. I take this distance and I move it horizontally, and I take the same distance twice laterally. And then I draw a small dome, like here. We draw this small dome. Then I have to draw a perpendicular line passing by TM, perpendicular to the thumb. Okay? And I report this distance B. I report the same distance here. Then I make the shape of the model. We used to do this splint, but with experience, we felt that the patient is more comfortable with having thermoplastic splint in this part as well, in the palmar part. Here you see, this came like this without this piece. It's exactly the shape. So instead of putting Velcro inside, we decided to add a piece of thermoplastic And I will show you later. I will do it on Nicoletta, and you will understand well. We decide to close it just on the back side. Okay? So if you want, normally the thermoplastic, we take our piece of paper, we put it on the thermoplastic, the orphic sheet, we draw again, and we cut the sheet, which is here.
We try.
We try always on the patient, yes?
Get correct size.
Okay, ready?
No.
Then, when my piece is already warm, we ask the patient to be on the position. This is the one, Nicoletta, let me see. Yes, it's the one. I cannot hold this, sorry. When I work, I cannot hold the microphone. Okay. So this is, so we put the splint. This shape is the space here, and then I close like this. No, I ask always my patient, yeah, the thumb should be in opposition. Okay, and we close here. Like this. Then I make sure that the thumb opens a little bit, otherwise I won't be able to remove the splint anymore. Okay? We don't have to push too much here to not make marks with our thumbs or our fingers. So we go very gentle with the thermoplastic, and then when it becomes cold, the splint is ready. I just have to adjust many things. We have to keep the wrist free, so we'll do some adjustment here, yeah, exactly, and I will cut here as well. So this is the thumb. What we do, the first, I always re-put my splint a little bit on the water to shape the thumb a little bit to make sure that the edges here doesn't bother the flexion of the MP, or the PIP, sorry. Okay, then I will check with my patient. So this is free. I have to adjust here. I take a pen. I adjust here. I will fold all this part. I will cut all this one and eventually this one. So I always cut the coins. I circle them. I mean, to not keep any sharp edges. Okay. And here I will hit it. We can use the heater gun or just a lighter to warm. Again, the part I'm gonna fold. Okay. So, it's not one yet. Okay, so I make sure it's well folded here. Okay, then I cut again all the extra stuff here. Okay, I will check the splint on the patient, make sure the wrist is free. I can also bend a little bit down for the same reason, just to not have sharp edges. Okay, so And then we close our splint with the Velcro, which there are different types. And we have this one, or we have this one. This one is pre-cut. And this one, we just have to cut, check the size and cut. So it's easier for us to use this one now. Same thing, I have to warm a little bit the sticky part, warm a little bit the splint, then up. I stick the first one, go for the second one. We warm it to make sure that it doesn't take off. Especially here in Qatar with the weather, it's too hot. So sometimes the patients are always coming back telling us that it doesn't stick anymore. So I cut the extra and again on the patient, up. I take a piece from here to close the splint. So up, up. I make nice shape everywhere. So
Perfect. So,
finish,
thank you.
splint, done.
Yes, and she's really quickly. So, the advantage of this kind of splint, as you see, must be the patient 1 week, 10 days after the traumatism to reshape the splint. It's really important. So, this guy is falling down after this shooting and he's falling on the left hand. And he come because he's swelling, he's painful on the basis of the fifth metacarpal. And this patient has a fracture of the neck of the fifth metacarpal. And it's really common when they fell down with the fist that is closed. And this fracture can be non-displaced like on the left side, but if you look on the right side X-rays, there is a flexion of the neck with more than 40 degrees. And sometimes, when there is 30, 40 degrees, there is need to do an operation. But the most important is not only the X-rays and the displacement. For all the fracture, all the hand fracture, you must ask to the patient, even he's broken, to flex the finger. You know, when you do this, all the fingers are convergent on the distal part of the scaphoid. Here, on this guy, with this fifth neck fracture, there is a malrotation, and there is a flexion, but a rotation in the fracture. We cannot see this on the X-rays, not so well, and you must examine the patient because this is needed to be operated. The fracture must be reduced and fixed. If there is any displacement, we will discuss about this splint. This splint was described initially by a French surgeon, Thomin. It's a splint to avoid any displacement of the fracture of the metacarpal. It's in intrinsic plus position. If there is any displacement, close reduction with pinning or open reduction with plate and screws. So it's challenging for Nicoletta, so we will explain how to do this splint. And you will see for this kind of fifth finger, he will have only the metacarpal of the fourth and the fifth that will stabilize. The thumb, the second finger and the middle finger is totally free, so the patient can continue to use his hand with this kind of splint. So, Nicoletta or Michael? Okay.
Okay. This splint is a little, it's a big challenge for us. So we decided actually to cut it, we draw it on her and we cut it, we melt it, we just shape it on her so you can see well easily how it is. Now we'll explain you how we shape it, how we do draw the model. We'll show you the paper model, the other model, and we'll melt it again and we'll just shape it again faster. Otherwise it takes too long time. Okay. Mainly again, we put the hand on a piece of paper, and in this case really has to be very, the shape should be even more precise because we really need precisely the place of the PAP of the fifth and the fourth. So we are going to draw the fifth and the fourth, which will be shorter in front, and we'll draw them higher a little bit in the back. We'll draw all the shape of the hand. We'll draw the middle line again. Oh my god, I cannot do it with this. We draw a middle line again, which is the cut line. Actually, no, it's not the cut line anyway. We draw our cut line is this one actually. We put the X on the cut line is this one, where there is 5. This is our cut line. And we draw the hole, the part of the hole. I'll show you. Later on we take our time. If you want, you give us one of your hand and we'll draw directly everything. The shape we have is this one, is exactly that one. And we will report it on a soft piece so we can really see. We check. We have the shape under the PAP, the fifth, goes back higher here. We have the other 2 frame in front. We know in the back it goes till here. We want to have the cut line between the second and the third meta to have more protection. And we have the hole where the thumb will come out. We know here will go back, and exactly it will cut between the second and the third. Okay, this is on her hand, so it's a little bit. And what is coming out is exactly this. Yes. You see, we have to keep the wrist a little bit in extension, in a rest position, a little bit in extension, 20-30 degrees of extension of the wrist. Little flexion the MP, metacarpal phalangeal, about 50 to 60 degrees. The thumb is free. We make actually the hole a little bigger than this. And the MP of the second and the third are completely free. And in the back, we have it's protected really until the third metacarpal, and the opening is between the second and the third, exactly. And here, these 2 fingers are completely free. And normally we use the Velcro to close down here, up here, and we use a small Velcro up here between these 2 fingers. So it will be locked here. You want to melt it?
Okay. Continue. So we ask a question after this. So this was for the hand injury. Yes, you want? Yes?
Splint is for a fracture of the metacarpal joint or for the...
It's for the fracture of the metacarpal, not carpometacarpal, metacarpal, and carpometacarpal if you want, but...
But usually the principle of the mobilization after a fracture is the joint below and the joint...
Yes. So in the metacarpal, you stabilize the metacarpal phalangeal and the wrist. So the only thing, yes?
Can I add one thing? It depends on the fracture, where either it's in the neck or in the calf or in the base of the metacarpal. And when it's close to the neck, sometimes we can, if it's really simple fracture, we just make it as hand-based. We don't involve the rest. Because the interosseous muscles between the carpal bone, it gives good stability for the metacarpal bones. And that's the only fracture where we don't immobilize the joint before and the joint after.
Exactly. There is a second school. This is one school. There is a second school we used to do before Bernard comes and join us in Aspetar. We used to do a very small splint, a gauntlet, with the wrist free, all the MP free, plus syndactyly. So it was something totally different.
There is different school.
Yeah,
I think
exactly.
if you decide to not have a surgery like for this patient, put a syndactyly, because when you move finger like only the PIP to DIP, there is some big force that you can have. You can displace your fracture in rotation. So if you decide to treat a neck fracture non-displaced, you can not immobilize the wrist, but put a syndactyly because you can have finger torsion and you can have displacement. So it's important. So I will give you 2 cases of wrist injuries because there is a lot of things that can happen about the wrist as the finger. I give case that I find this week on the handball player and which are really common. And one of the classical wrist injuries is the patient, he fell down on the wrist in hyperextension and he come to you with a pain on the radial side. It's classical a scaphoid fracture. And the scaphoid fracture is, the mechanism is a forced dorsiflexion. And the patient come to you with pain on extreme motion, and on the scaphoid there is a little bit swelling, but not usually. And you know that for the fracture of the scaphoid there is 2 different mechanisms. One, compression injury, that's one for the more classical, and the other is the hyperextension with a bending injury. What is important to know? The vascularization of the scaphoid. There is 2 different vascularization. They are coming from the radial artery, the palmar branch and the dorsal branch. And the dorsal branch give the vascularization of 80% of the proximal part, and the palmar branch give 20% of the vascularization of the distal part. It's really important to know it, because if you have a fracture that go in zone 3 from Schoenberg here, the vascularization of the proximal part is cut, and maybe you can develop some osteonecrosis on the proximal part, especially if you look at this here, the dorsal branch, they are going until the proximal part. You see here there is a no man's land of vascularization. If you have any fracture here, how do you want to heal and to avoid any necrosis at this side? It's impossible because there is no vascularization. There is Herbert is well-known American surgeon who described very well the fracture of the scaphoid. In Europe, especially in French, we prefer to use the Schoenberg classification because it's more complete. And in this classification, cut the scaphoid in 7 parts. And the fracture in zone 1, like this, is a proximal part of fracture of the scaphoid. If you see here, this part is really small. You must fix it if there is any displacement. I put here a zone 3. You see a complete and stable zone 3 fracture. If you see here a zone 4, not unstable, and a zone 6 on the tubercle fracture. But when the patient comes, you must examine the patient and show that he has pain on this part and ask 3 different views: AP view, lateral view, and a scaphoid view. Because sometimes when the patient comes on the first day and you go a little bit too quickly, you can miss this kind of fracture on zone 2. You see, if you don't have the experience, you can miss this kind of fracture. So a patient who comes with pain on scaphoid, especially to a sport with an injury, high energy injury, in dorsiflexion, you must expect it's a scaphoid fracture unless you prove it's not a fracture. Because if this patient comes 31 months later, you see, he has this patient missed the fracture in emergency. He comes 1 month later with the same pain without any immobilization. It's a displaced fracture. So for this patient at emergency, if he receives a brace or a cast or a splint, the fracture will not displaced. Here the situation is totally different. He needs some surgery. So if you have any doubt, don't hesitate. Ask to the radiologist to do a CT scan or an MRI. The CT scan is really, really helpful to see scaphoid fracture. And sometimes MRI can show some bone bruise at the first stage or some in old fracture, some osteonecrosis. The conservative treatment is a wrist splint with small extension and immobilization of the MP joint, and this splint must be stay for 2 to 3 months. At 3 months, do a CT scan control. If you don't do a CT scan control, only a scanner, you can miss maybe a delayed union. If there is any sportive, I recommend it's better for the sportive to take the re-education and the training quickly as possible to do a small percutaneous osteosynthesis with a screw. So it's time for you girls for how to do this kind of splint.
Again, the same thing. As you see, it's more or less the same shape of the previous one with the thumb, but it's just longer. So for this splint, we have to take as much as we can till maybe 2 centimeters before the elbow, just to keep the elbow free. So it's exactly the same concept. We draw the hand, but here we don't stop till the wrist, because we take all the forearm as well. We draw the line in the middle, and we report exactly like the previous one. So the distance A twice with the dome, the distance C, and now the distance D, which is the distal forearm part. After that, we shape our model. Same thing, we put it on a thermoplastic. It gives us more or less this shape, which is already in the water. I hope it's warm, and we do the splint. It's the other one, Nicoletta. Yes. Okay. So we put our splint here. We close same as before. You always ask the position of the thumb. Up, and we go fast. Exactly the same. Up.
So the functional position is a small flexion.
And we go slowly with our thermoplastic down. Very good.
It's necessary to have a longer splint on the wrist until the forearm, because it must stabilize the wrist.
Okay. Same thing. We adjust the thumb. We adjust exactly the same as the previous one. We put here 3 velcros, not only one. So one on the top, one on the middle, and one on the last part. We close it and finish. Okay?
but it comes with frustrate pain in the middle of the wrist. It's difficult to know where is it. And you do some X-rays, there is no scaphoid fracture. You do the MRI, the CT scan, there is no fracture of the scaphoid. It's a lesion of the scapholunate ligament. One is the most important ligament in the wrist. So there is two big intrinsic ligaments in the wrist. You have the scapholunate between the scaphoid and the lunatum, and the lunotriquetrum. And there is extensor and extrinsic stabilizer, like the dorsal radiocarpal triquetral, the laterocarpal ligament. The examination of this painful wrist must be see all the mobility and see if there is any clunking motion and any Watson test. The Watson test is the test when you move the finger, you avoid any mobility on the scaphoid. If there is any lesion of the scapholunate ligament, you will have a pop sign. And you see here on this surgery, the scaphoid, the capitatum, the lunatum, and here you will see the scapholunate ligament with torn. And you must do X-rays, because on severe rupture, you see you can have a big hole between the scaphoid and the lunatum. This hole is due to this ligament injuries, and you have different evolution of the instability. First, it's dynamic, so you must do some dynamic X-rays with when you close the fist, and you see there is a difference of the normal and when there is any lesion. It's necessary to see the angle between the scaphoid and the lunate, because if this ligament is torn, you will have a dizzy. So the lunatum will go in the dorsal position and the scaphoid in palmar. If you have any doubt, ask to do a lateral CT scan. And you see here this patient has a ligament, you see in black. The scapholunate ligament is still there between the scaphoid and the lunatum, and the lunotriquetral too. You see here this patient, we don't see anymore the ligament. On the axial view, the volar and the dorsal part of the ligament, scapholunate ligament, and here you see there is still a volar and there is no more dorsal. And the dorsal is the most important part of the scapholunate ligament. And if you confirm the rupture and there is no static instability, you must grade this instability and show that there is no cartilage lesion. And you must perform an arthroscopy. And you see here, you see the scaphoid, the lunate, and you see this part is the scapholunate ligament. And you can, with the scope, go through the both. And this is a big instability. And for the sport, when you do nothing, you can tell him in 8 to 10 years, he will develop arthritis in his wrist. So here is when you see in the mid-carpal joint, and you see between the lunate and the scaphoid, there is a mild instability. And we have a good classification described by the American Geisler and modified by Gilles Dautel, a French guy. And if you have an acute lesion, it must be surgically managed. So the best result is when the patient is operated before the 6 weeks after the injuries. And you must reduce the scaphoid and the lunate, put pin between the scaphoid lunate and the scaphocapitate to stabilize. And then with anchors, you reattach the avulse ligament and you can reinforce with capsulodesis. This is the good results in emergency. After this, until we retrieve the material for 6 to 8 weeks. The patient will receive this kind of splint, and you see it's a wrist splint that you can use for fracture of the radius, isolated fracture of the radius if you want. It's a wrist splint to stabilize the wrist for the time before hardware removal.
Again, a splint. So, again, we draw the hand of the patient. First, the middle line. Second, the MCP joint line. Third, the wrist line. And the fourth, the last forearm. We report the same. We report C distance laterally, bilateral, okay, medial and lateral. Same for D. And after that, we draw our hole. How we draw the hole? We take more or less the same, the distance of the, the phalange size to draw a circle, but this circle has to be more or less on the same line of the TM, trapezometacarpal joint, okay? Then we take the hole. On the middle of the hole is here. On the middle of the hole, we fold our paper like this. Then we take scissors and we cut the line, the MCP joint line. When you open your paper, you have automatically this line ready. Then I shape like here. Sorry. Okay. So I shape again the splint. I cut it on the paper. I put it again on my thermoplastic or fit sheet. Cut it. Warm it. And again attach the velcros. So up, we go fast. With the splint, we have to really go fast. Otherwise, if it becomes cold, we cannot shape anymore the splint. Relax, same position. With the wrist in a little bit of extension, and then go. The splint is done. Just wait. This one has already. And as you see, we have many colors. We have the gray, the black, the green, the pink, the gold, the blue, purple. After, at the end, if you want, you can just come a little bit closer. We can show you all the colors we can get. We have also pre-done Sandactyli splints, but not splint. It's quite good. The Sandactyli.
Yes.
Yeah, we have many stuff. So just come a little bit closer, and we'll show you what we have. Okay. Finish. I remove the splint. I have to cut a little bit this part. Okay. And then we close our splint like this. Up. We like the pink, that's why we finish
With the pink.
Yeah, exactly. Okay?
So this kind of splint you can use for a lot of injuries, other injuries like fracture of the distal radius ulnar. So you have see what we can perform for the patient, and especially for the sports, because with all this kind of splint, our sport player go back to the training with this. So, any question? question?
We give your hand to try.
The question is for you, doctor. Because I hear that you just say before that with the finger spring you can train, you can play. But as far as I know, FIFA does not allow to play with any kind of this thermoplastic spring in the fingers. FIFA. I don't know any other federation.
I don't know the legislation of all the federation, but in fact in FIFA you cannot, but you can continue to train.
Yeah, train.
So it's the most important for the sports, because if you tell to the sports you have a finger injuries, you cannot training, and you can do any fitness for 6 weeks or 8 weeks for a finger, it will be a disaster. So
Yeah.
no, he can play any tournament, maybe, but he can continue to play in training and during the normal activity.
Yeah, and my second question is because I just recently saw a player, national team Qatar from Egypt, one of the best, and it has a total avulsion of the MCP ligament.
Yes.
Which one is your consideration to decide whether to operate it or not?
MCP, which MCP ligament?
In the thumb.
Yes, there is any stellar lesion.
Well, now as far as I know,
So
no.
first, as I explained, do an ultrasound. If there is a complete MCP without any sternal lesion, there is no indication to surgery, but there is an indication for immobilization. So first, immobilization for 4 to 6 weeks. And if there is any MCP ligament with a sternal effect or with bone avulsion and displacement, it's an indication to operate.
Thank you.
Yes?
Yeah, you showed for a...
Wait 2 seconds for the micro.
Sir, nice presentation. You showed me about all our PIP joint
Yes?
ligament, polar plate injury. So and you keep an extension, but ideally in a clinical facing, we start in flexion. The dorsal
Yes, so the dorsal splint, it's a small flexion on 10 degrees. Corrected, because if there is any fracture, put it on 10 degrees of flexion. But don't put on a 30 or 40 degrees of flexion, because it will hold in this position. And then after this, you will fight to recover the extension. If you put at 30 degrees PIP joint dislocation, you will never recover the extension. So don't put in hyperextension or neutral. 10 degrees of flexion, 10 degrees is not lot, it's like this, okay? And during the day, mobilization, stabilization during the night with 10 degrees of lag extension. So 10 degrees of flexion.
So you are clear that it was not rupture, because all our plate rupture with this little more.
No. You know, one of the bad evolution of the dislocation is the stiffness and the flexum with 30-40 degrees.
Yeah.
So, and when you have a patient with this, it's more difficult to recover the full extension than to put the patient in extension directly.
Okay.
So, no, not too much flexion as 10 degrees.
Just to confirm that it was a dislocation, not the rupture, because rupture.
To both.
No, because
the rupture do the same.
but we see a patient clinically like more than 30 degrees down, and every week we dynamically work on just increasing the dorsal, because splint is not static as far as we concerned. Like a static means not dynamic splinting. We change all time regularly. Because on the own, like
Yes,
say,
but,
same splint, modify, extend, gradually extend and get around.
Yes, it's why this kind of spring is really interesting, because you must follow your patient every 10 days.
Yeah.
And change the splint on the finger. And you must have an evolution.
Yeah.
It's normal, yes.
Thanks, sir.
You showed earlier the fracture of the head of the fifth metacarpal and splinting, you included the thumb. Any additional rationale for that one?
Excuse me, I don't know.
Fracture of the head of the fifth metacarpal. But in the splinting,
Yes.
you included the thumb earlier, what I saw.
They don't.
Yeah, forearm base with the thumb included.
There,
Because,
the
yes.
fracture is
Yeah, yeah.
here, like for example here.
Big
but
metacarpal.
They included also the thumb in that.
No, the thumb is not included. The wrist is stabilized, but the thumb is not included. It's completely free. Huh?
I don't know.
The CMC is completely free.
No, no. In this MCP joint here.
No. The CMC is free.
Yeah, here. And the base joint here.
This is the one. This is the other one.
This is
So the UCL, but the
Yeah, but the previous one
Yes.
giving limitation for the MCV of the thumb. You can't do like this. Can you do like this with the split?
Yes, sure.
No, we said this.
Oh,
No, we said it, we're going to open it more.
it must be.
So it must go up to palmar
No, we
crease.
don't do like that.
Okay, so
Keep it-
to allow this, you
It's
get
exactly-
stability, but you get like you don't need to immobilize the thumb because the fracture is here, so there's no point of immobilizing. Because functionally, you need the thumb to be free for the player because
I will tell you something. Actually, it's exactly the same. There are two schools.
Yeah, exactly.
Exactly. Before I told you, before Dr. Bernard joined us, we were doing a small gauntlet and we were doing a very big opening. Okay, since we went to Luxembourg, they are doing this kind of. They don't open the thumb too much. For them, if we move the thumb, it can
We leave some.
yeah.
We leave some mobility, but not full.
Not
We leave some. but
You will not
full
have
like
any
this.
stiffness.
What is the rationale behind not moving the thumb?
It's more stabilized the wrist.
Okay, but the fracture is in the metacarpal.
Sure. Yes, but
Try.
you must stabilize the wrist too. You know, if you
If I move my thumb, my little
You
finger
move
moves.
you know, we use the same procedure for the fifth metacarpal as for the second metacarpal or the third. So it was an example, but you can modify this splint to do a fracture of the second, the third, the fourth, and the fifth metacarpal. You only place the stabilization of the MP joint, but the splint is exactly the same. With your splint, it's a specific splint only for the fifth metacarpal fracture. But it's not stabilized the fourth metacarpal. Your splint stabilizes not the fourth metacarpal. And you know, when you have a fracture of the neck, the ligament between the fourth and the fifth is torn. So, okay, if you have a fracture non-displaced, quite stable fracture, it works. If you have a fracture non-displaced but unstable with your kind of splint, you cannot stabilize only the fifth without stabilize the wrist. So if you want to stabilize the wrist, you must close completely the wrist.
Totally agree with you, doctor. I totally agree. But like there's some point when we are working with the patient, we agree on something that we don't need to stabilize any joint that really is unnecessary. Because our aim under to maintain the function of the patient, to make them independent, to let them play as much as we can.
Yes.
Because of that, I think he's a little bit conservative of restricting the thumb movement.
Yes, yes. But
There are more conservative surgeons and there are less conservative surgeons.
But anyway, the thumb is free. It's not, so you don't have the position, or you decide how much you need.
you will not have any stiffness on the thumb and the wrist with this. But I totally agree with you about the immobilization of the joint.
Actually, it's nice to discuss about two things because I was just giving a little two schooling of because it's still like 75s, 1915s, they were only one what you are doing. Okay, say 15, the Germans came with the transmetacarpal bar splits, only above the wrist, below the metacarpal. That's quite, they had confirmed with another study like seeing the metacarpal action in EMG biofeedbacks. So it is not actually hurting if it's unstable. If it's stable, if they put the microplates in, still you can go on with the transmetacarpal stuff. But if you're uncertain about the things and you find many things like we don't know what kind of injury we have, interstitial injuries, we go for long supports. When I've been using this splint for like transmetacarpal for these kind of intervention, almost 600 splints on the transmetacarpal across third, fourth, or even the second with the surgeon's consult. It was no failure, but the school of thought is different, and then the interlock between the surgeon and the therapist is an important thing, because if you and the patient, the cognition of the patient, suppose he doesn't bother about the splint and just go and casually walk out, that's going to be. And again, the age population, pediatrics, this is the most best suitable splint. Even you can go higher up.
So we show here different type of splint.
Yeah.
There is book with different evolution of transmetacarpal, basimetacarpal, and the neck of the metacarpal, and so it changed a little bit the configuration. There is no need to immobilize the MP joint if there is a fracture of the base.
Yeah.
So
I
totally agree with this, but
no, the thing is, like, the school of thought is different. Only thing, just that's all.
Sure.
So there's no difference. We may still argue on that. Thanks a lot. Anyway.
Do you want to see here for the splint or any question to my colleagues? So it's time, I think.
Yes.
Perfect. Thank you very much.